Well, it's 1 o'clock, and we are very fortunate today to have Dr. Amy Bat, who will be discussing optimizing telemedicine. But before we go on, let's just do some housekeeping. Next slide. So there is a CME with this webinar, and at the end of the webinar, kindly use the QR code or log in to our CME website to get the important webinar CME unit points. Next slide, Laura. And make sure everyone's name is in the participants list. And if you are viewing in group, just put in the chat box your name and email, and we were more than happy to send you in your CME credits after you answer all those vital questions. Next slide. So I have here the CEO of Texas Tech Physician, Mr. Brent Medjers, who will introduce our special guest for today.
Thank you, Dr. Santos, and good day, everyone, wherever you are listening in. We appreciate you tuning in today. I think you'll be very pleased that you did, because we have an outstanding speaker that I will now introduce. Dr. Amy Bat is the Director of Outpatient Cardiology and Telecardiology at the Massachusetts General Hospital and an Associate Professor at Harvard Medical School. She graduated from Harvard College and the Yale School of Medicine and completed her medicine and pediatrics residency at Harvard, her adult cardiology fellowship at Brigham and Women's Hospital, and her adult congenital heart disease and pulmonology hypertension fellowship at Boston Children's Hospital. She is an active clinical cardiologist, investigator, and educator, and founded the MGH Adult Congenital Heart Disease Program in virtual care in 2013. So she's been doing this a while. Her research centers on identifying and implementing solutions to barriers to access to cardiovascular and telemedicine care. The COVID pandemic has amplified the disparities in access to healthcare secondary to disease complexity, health literacy, social determinants of health, and risk widening the digital divide. Dr. Bat works with national cardiology organizations, hospital administration, and design teams to dismantle the barriers to care associated with optimal cardiovascular outcomes. She serves as a medical advisor for digital and telehealth companies, advocates for policy change in telemedicine legislation, and leads national telemedicine education via the American College of Cardiology. Dr. Bat also serves locally on the board of the American Heart Association to increase awareness, access, and patient self-advocacy. Internationally, she assists countries affected by COVID with an abrupt need to deliver remote care. Her interest in digital health strategy stems from her belief that state-of-the-art personalized care can be delivered to individuals in the community, empowering patients and creating stronger clinical patient partnerships for sustainable health outcomes. It is a true treat today to have Dr. Bat. And so Dr. Bat, welcome to our program, and we're turning it over to you.
Great, thank you so much for having me. So let me just share my screen. And you guys tell me when you can see this, and I'll make it big so it's a little bit easier. All right, how's that?
Looks good.
Looks good.
Okay, great. We'll hide up. We'll hide. I don't like watching my own face while I talk, so we'll put that away. Thank you so much for having me. So I did start telemedicine back in 2013, and I'll tell you the story in a couple minutes, but it's interesting to me to also see the difference in how telemedicine uptake has affected different areas. And I would say that both inner city, but also rural areas have always been harder hit, have been much harder hit during COVID. And I think it's a place where if we can do telemedicine right, we can really make a difference. It's an honor to be here and discussing this with all of you today. So emerging models in healthcare delivery, thank you for that very generous introduction. We'll try and do three things today. So the first is We'll talk about the concept of blended care and being agile in how we deliver care. We'll then talk about some actual models of telehealth that incorporate virtual care and some digital health monitoring. And then I'll try and demonstrate some key facets of what I think makes for successful telehealth implementation. I will try and leave more than enough time at the end to actually talk about specific questions that you may have, or incidents, or other things that we want to go over in terms of your actual interest in telemedicine, practice, or companies. So we'll try and leave about 20 minutes at the end. So first of all, just thinking about telemedicine trends in the US, I think is a great place to start our journey. And if we look at ambulatory visits by type and US region, the first thing we recognize is by the Epic Health Research Network is that it really does vary depending on where you are in our country. So up here we see in light blue, we're going to look at office visits, green telehealth visits, and purple just total visits. And we can see back in 2020 before COVID, the majority of the country was not doing telemedicine. And there was an increase in those telehealth visits that then decreased as office visits really went down dramatically and then increased. But what I want to focus on is down here. So here's where I am in the Northeast, where we had, not much telemedicine. We started, and then as you can see, we maintained telemedicine despite the blue line of office visits going back up. So we actually increased the number of patients we were able to access and to see by adding telemedicine to our usual care. If we look at the South here out of interest, we can see again, not a lot of use of telemedicine, maybe a less robust increase in the use of telemedicine, and then really a decline back down to, almost very few people, I think current company excluded, who are continuing to do telemedicine, whereas the office visits really went right back up to being almost the total of the number of visits. And so we notice that this varies throughout our country. There are a few things, though, that will affect the entire country, and I think these are the legislative trends to look for. The first is payment parity. So we don't think that telephone visits will be, at least in the near future, paid the same as an in-person visit for a variety of reasons, mostly one of measurement. The concept of video visits is a little bit different in that there's a lot that we can do and connect with our patients about on video, even if we cannot have a hands-on exam, although we are trying to change that as well. And so I think payment parity will come first for the video connection before the telephone. However, I think it's important that majority of our Medicaid patients actually really rely very strongly on the use of telephone. And so in order to provide good care to some areas, we need to continue to be able to connect with our patients. And it would be great to be able to do that in a way where those people who are providing that care are actually compensated for the work that they do. And then lastly, cross-state licensing is quite a challenge. So there are areas of the country that have started to allow cross-state licensing such that if your patient is in a state adjacent to yours, you can provide care. However, even when the states agree at their own level with a compact for that kind of care, some of the insurance companies have not been comfortable offering malpractice insurance across state lines. And so there's a lot of groups we need to get on board to ensure that cross-state care can occur. The argument against cross-state care, I won't disagree with. There are areas that are rural in our country where if we start providing telemedicine care, one of the attorney generals in one of the states up in our area mentioned this recently, they're worried they won't be able to have enough doctors who are actually local for when people do need in-person care. So the rationale behind figuring out what that balance is of in-person care and virtual care in rural America is really important. There are most certainly House bills that are currently safeguarding access to telehealth during COVID. There is also several pieces of legislation trying to move forward to extend this beyond the current year. Unfortunately, with Delta rising, as you well know, I think there's going to be extensions on a lot of the COVID work that's being done, which gives us more time to think about what the final picture will look like when we eventually get through COVID. And then there is evidence. So there's research that shows that safety net organizations, this is in California, so the Medicare, Medicaid population as well, really does use telephone as telehealth. And so again, just emphasizing that video visits alone will likely leave behind a significant proportion of our patients. If we think about HR 133, which is the actual Appropriations Act that gave some money, these are the kind of dollars we're talking: $1 million for a telementoring training center, $4.5 million for collaborative learning, $6.5 million for telehealth centers. So all told, about $250 million for telehealth during COVID. Expanded rural broadband has been a big part of what we are fighting for kind of nationally. But I wanted to show you something different, just thinking about funding growth and what that means. So here's Rock Health did an analysis of telemedicine funding. So this is funding in 2019. You can see by quarter about $100 to $200 million. And here's in 2020. In quarter three of 2020, $720 million. This is in private companies investing in telemedicine. And if we look at utilization, we had about 27 million telehealth visits. This is based on Medicare fee-for-service claims. And then if we look globally, telehealth startups raised $3.3 billion in quarter four of 2020. So I only bring this up to make the point that I don't think we're looking at government and academic institutions or clinical practices alone in making telemedicine something that's here to stay. I think it is a good thing. I think we as clinicians especially really need to think about how it needs to be designed. But there are a lot of people outside of the healthcare industry who have quite a lot of money that they are already putting into what they're calling telemedicine. And I think it's an opportunity for people like yourselves, I'm honored to speak with this group, who have really been, doing this at the ground level to perhaps think about how can we get some of these dollars and some of these people to understand the good work that we do. So blended patient care, with that kind of overview, my thought about telehealth, I do not call it a disruptor of the practice of healthcare. It augments the traditional delivery of healthcare. It enables a more agile and continuous mechanism of care provision. Not I'm going to see you once a year, but rather I'm going to know what your blood pressure is throughout the year such that I can make moves on it and make improvements so that you don't develop heart disease, stroke, kidney disease as we move forward. And engages the patient more strongly as an equal partner in their care. So telemedicine requires that the patient know what they're doing, how they're caring for themselves, understand it, and participate, which I think is incredibly important if we're really going to become a preventive care model eventually. Who are our patients? So our patients are used to having improved access. They're used to having optimal convenience. They have apps now that tell them where in, Walmart or Target they're going to find what in which aisle. So they're very used to being able to access things both digitally and in person as they need it. They are interested in home-based care and they really want a holistic investment. So there are many, many people who have a lot of anxiety and depression, period, in the United States, worse so during COVID. And people want that to be addressed as much as they want their lung or their heart disease or their diabetes to be addressed. So they're ready for a personalized approach. And I think our patients are maybe even ahead of our field in medicine of being ready for doing continuous care using telemedicine. So where do we fall in this? I use the we to represent clinicians and administrative leaders. We always have some tech enthusiasts or visionaries. We have some conservatives and skeptics. But what COVID has done, if nothing else, is it's made everybody a pragmatist. So we all recognize that there is some degree of telemedicine that needs to happen for us to continue to provide care. And that's not going anywhere, nor should it go anywhere even when COVID goes away, because it's just a better way sometimes to care for patients. We're also pragmatic about the fact that there are certain things that we cannot do without the laying on of hands. And we should not be people who suggest that that can happen sooner than it is really going to. And so I think that's important. It's really bringing our edges in closer, bringing our tech enthusiasts and visionaries to be a little bit more pragmatic about the really big picture, and our conservatives or skeptics to be cognizant of the fact that we really do need to incorporate this into our workflow. So I'm going to take that to go to workflow, which is without a good clinical workflow for delivering telemedicine, digital health, telehealth, however you want to define what you're doing, it doesn't work. We have found this again and again. And so you need a detailed workflow for every person in the unit to say, if there is a patient, who will first talk to them? How do we describe what telemedicine is in the way that we're using it? How do we know they're right for it, and how do we help them get it set up? How do we help the physician or nurse that's doing it? Who is going to look at data that's coming in? Who's responsible for the scheduling? And so there's a lot of steps. And so this is what we did back in spring of last year, which was we really just set up every single step, what happens next and what are we supposed to do about it? This is only one example of a clinical workflow. We had several clinical workflows for all the different areas that would touch the concept of, can somebody have a virtual visit instead of in person? That's in the hospital. That's for a consultation from doctor to doctor. That's for a new patient coming in who has a question. And now we even do it more specifically. That's for a new patient from within Massachusetts, for me at Massachusetts General Hospital, versus somebody outside of the state. And so I feel a little bit more administrative than I ever did before. But I will tell you, without the workflow, it's too complicated. There are too many people in medicine that touch patients and touch upon the process. And both the patient experience, but even the clinician experience or the team experience really declines when you don't have a clear workflow. So I can't emphasize that enough. So here's our MGH experience just for perspective. We only had 0.23% virtual in February of 2020 leading into the COVID pandemic. That was me. I tried to get a lot of people to do this. I started in 2013, mostly because I had a patient who lived on Nantucket Island and really needed congenital heart disease care. I was very glad to meet the patient and then told me I don't leave the island. And at the time, we didn't have a practice out there. In fact, I was just there this week. We do now have a practice there. And I then came across a couple others who lived in Maine and New Hampshire, one who flew in from California. And all these people wanted care, but they weren't going to come in to see me. And so our stroke service had already started providing on-site acute stroke help using telemedicine. Lee Schwam had started this. And so we asked and said, could I please use it for this practice? I then tried to convince all of my colleagues with no workflow whatsoever to try and do this as well. And a couple of them tried it, really didn't work because we had no workflow. We also hadn't improved upon the technology. It was a little clunky. And then COVID happened, and we were able to, in a 2-week period, turn everybody 98% virtual in the entire practice. There was 134 practitioners. A lot of people did a lot of hard work in getting that to happen. And there were people like research assistants who became tech support for grandmas out there in the community. So it was really a lot of people pulling together. I'll show you where we are now, because as you can see, we went very virtual when we had a real problem with COVID, and then we came down in numbers. And if you look here, I broke it down according to cardiology subspecialty. Each of these groups did a lot of hard work to make this happen. Here's general cardiology, heart failure, interventional cardiology, so our catheterizers, electrophysiology, or our arrhythmia doctors, and then our fellows clinic. And you can tell that just about everybody maintained a significant volume of virtual care despite the type of patients they were seeing, the type of exams they needed, the kind of interventions they were doing, and the type of practitioner who was there. And so it really was across the board. There was an ability to maintain virtual care for at least 50% of our population, no matter who it was. And what we really recognized is there were certain mechanisms that supported this transition. And the most important one, I would say, was the fact that we did not force anybody to do this. We enabled workflows and allowed any clinicians who were comfortable with it to use it as much as they wanted. We allowed those who weren't comfortable to go back to using in person and then find that once in a while they maybe wanted to do the virtual. And everybody started to find their own formula of what were they comfortable doing over video or phone, and what did they feel they need to do in the office. And that autonomy, giving that autonomy back, especially after COVID, was a really important part of creating a sustainable workflow and workforce of telemedicine providers at our institution. I show the Fellows Clinic because the Cardiovascular Fellows Clinic at Mass General probably represents one of the most socioeconomically challenged and one of the most diverse race populations that we have. And so I think it's important for us to kind of recognize what happened there. And you do see that in the green, the virtual is maybe 40%, and then the in-person is about 60%. And we're landing somewhere in that, or maybe even the 30-70 range as we move into 2021 with this group. So it is still possible, but there is some laying on of hands that is necessary. There is also a lack of access to technology to be able to successfully complete some of these visits. And the decision amongst the fellows and the fellowship leadership at Mass General that the in-person interaction is important enough that it needs to happen over phone alone. And so that's how we've ended up in this range. And I suspect a lot of the country will end up in this range as well. So what is the telehealth landscape now? So there's asynchronous communication, not at the same time. So patient-reported outcome measures, electronic consultations, hey doc, I'm thinking this, what do you think? Blended care, practices that have in-person but do also some virtual video visits. We have clinical remote monitoring, especially in cardiology, and medical grade devices, but we also have, continuous glucose monitoring. We have blood pressure cuffs that people use at home that can upload to your system. And so that's increasing. We have weight scales at home. Increasingly, people are using digital tracking and wearables. We need a system for bringing that data in before anybody decides to use it regularly in their practice. Otherwise, I think we will get in some trouble. And then we have some emerging analyses. So there's a lot of artificial intelligence that is not, I think, ready for prime time yet, but I'll go to one example of one just to show you what it can do. I did want to give some kudos and thank this group for working with me. So Kumar Brown and Jambi Mathenge worked together, they're two fellows at Mass General, on looking at the social and clinical determinants of telemedicine cardiovascular care. And we wanted to see who wasn't using video, who was either not being seen or just using telephone or insisting on coming in despite COVID, but who wasn't able to engage with video, which we were doing so well. It is those with public insurance. It was our African-American population. It were those of Hispanic ethnicity, a low median household income, which by the way, in Massachusetts, the median household income is around 70,000. So it's actually not that low, even when it's lower than our median average. Those with heart failure, both heart failure preserved and reduced ejection fraction, and the elderly over age 85. We had great success in the 60s and 70s with people using technology. And so these are the groups that we're now focused on. And through a grant from the Association of Black Cardiologists, we are now enrolling these patients in our patient portal or MyChart. We have donations through the population health group at Mass General of tablets for these individuals. And then we are sending out navigators to do digital literacy, teach them how to use the devices, and essentially assigning them both a telemedicine coach from our side, but also someone in their community who's good with tech to help them get engaged. And we are now trying to proceed with those navigated encounters to find out what we're doing wrong, because I'm sure it's not going to be perfect just because we set this up. But the next step is to say, if we try this, where are the holes, where are the barriers, and what can we do better? And so that's the stage that we're at right now. And hopefully by next year, we'll have some good data on that. So where has telemedicine worked? I thought I would show you a case or two just to kind of show how this works. This is actually pre-COVID. This is a patient I met who had pulmonic valve disease. He actually had 2 surgeries before, open heart surgeries, one as a child, one as a teenager. And he came to me for a very first meeting. And I'll just show you a picture for fun. So this is an echocardiogram of his heart. And here's his valve. So you can see the struts and then the valve that's held into place. But you'll notice that there's this black space here, some floopy thing, right, and some space. And so we put some color on that. This is color Doppler. And you see flow going here through the middle of this valve in this direction. But unfortunately, you see a regurgitant jet right here going backwards. And that's a huge leak next to a valve that is now kind of displaced. We call it paravalvular leak. And so unfortunately, this person, there is only one solution for this for him, and that was his third reduced sternotomy, opening up his chest, a third surgery. And we had our meeting to talk about this after he had his echocardiogram over video. And so I didn't want to do that because I had met him for the very first time. I heard his valve. I knew something was wrong. I got him the echo and I said, no, look, I picture Norman Rockwell as like the end all be all. I want to sit with you. I want to hold your hand. I want to tell you this. I don't want to be that doctor that does it over a video. And his response to me was surprising and very clear. He said, look, I'm not going to get a third surgery unless I have to. And the only reason I would do this is because of my kids and my family. So I need to be at home with my kids by my side when you tell me what I'm pretty sure you're going to tell me, doc. So could you please get on the video? I got on the video. And I told him, and he knew already, he knew from how badly he was feeling. He'd gone through this twice before, but really this was a use of telemedicine I wasn't expecting. I thought technology was putting distance between me and my patients. And it was the first time I recognized that actually for the patient not driving in, and now I have so many other examples, patients who say, I cry the whole way home on the Mass Pike. Patients who say, I flew home to my family and I was alone for so long in the airport. Patients who say, the way the hospital smells is different when you know you have to have surgery than it is when you just come in for a regular visit. And so there's a lot associated with coming into a hospital that patients don't like and don't need, especially when you're just having a conversation. And there's a lot to be said for them being in the comfort and with the power of their own home. So something I learned early on that I didn't realize was going to be an important part of why I do telemedicine. Here are current use cases, just so you can get a sense of what we use them for. The map on the right-hand side is really just a map of Massachusetts to make the point that, in terms of density of people who we care for now, those who live close to Boston over here also use telemedicine actually quite a bit. So these people are all within an hour of the city, but for convenience sake, some are hourly wage workers, others have to get childcare, others are elderly, don't want to slip on the ice, and others just, don't have the time or don't need to be examined and therefore recognize that they just need to have a conversation. So distance is not necessarily the driving factor. Convenience is a big driving factor as well. If you look on the left-hand side of the screen, I started using telemedicine for review of data. If you have an X-ray and you call a patient, you say, it looks fine. Not sure what that means, or it doesn't look fine. But if you send them the report, then they start reading things and they say, what is this small nodule and what is that? But if you show them the picture and you say, this is your heart, this is your lungs, here I see a little extra air trapping because you have COPD and that's why this lung looks a little more black than this one. People learn something about their own disease. They're walked through what they were doing, and it actually lessens the number of phone calls to the office as well about testing follow-up. So that's where we started using it. The patients then pushed us into the gray and the blue. The gray is routine follow-up. Patient said, hey doc, if you don't need to examine me this time, can I do it from home? And then patients say, hey doc, will you just talk to me first? Can you see me on video? And I want to tell you how short of breath I am. I used to get really nervous about shortness of breath, chest pain, being a cardiologist, but it turns out I can triage them much more efficiently when I see them using a video. I still ask the same history questions. I still find out the same information. I oftentimes need to see them in person. Sometimes I want to get a test in addition to that. And it's been really helpful to triage them locally to primary care, to the closest emergency department, or to a visit with me at cardiology. We now do some pre and post-op planning using telemedicine as well, especially as the COVID cases tick up again. It's better to keep them out of the hospital when they don't need to be in the hospital for some of these conversations. Second case, and then we'll talk about a little AI, and we will then have time for questions. This is during COVID. This is a 78-year-old patient of mine who has hypertension. So he has something called coarctation of the aorta, or a narrowing in his aorta, and you can see where we put a stent in him previously. His wife's a nurse and said, hey, I really think that he has hypertension, but he refuses to take his blood pressure. He's not really talking to anyone. By the way, we retired last year to take care of the grandkids, and now my kids won't let the grandkids see us because they're afraid they're going to get us sick because we're old and decrepit, which we're not. And so the whole world kind of fell apart for them. And so we started a program for these individuals where we send them a Bluetooth blood pressure cuff at home and directions on their phone as to how to download the app. And every time they use their cuff, it signals to the app, and it actually comes in like this to my electronic medical record. And so this is what we had, and these are his blood pressures. They were in fact high. He did this much during the peak of COVID in Boston. Every day he was giving me a couple of measurements, and we were able to get his blood pressure under control. That's, I think, not the success of this story. The success is once he started doing this, he recognized he was actually able to figure out technology and started to do FaceTime and Zoom with his grandkids. So they now, now they're in person again, although that may go back, but they started doing Zoom story time, and he got to see the grandkids again and really came out of a depression that COVID had put him in. So a lot of positives to the ability of teaching people how to use technology nowadays. We talk about phone, we talk about video, and people make this assumption that in-person care is better than video, which is better than phone, which is better than text, etc. And I think that's not true. And that's one thing I'd like to dispel. And I think your team will probably agree. You use the mechanism that works the best for the diagnosis, for the clinicians, for the patients, for the system. And so this is an example, again, sponsored by the Association of Black Cardiologists. And the group who had done this looked at telemedicine to improve maternal cardiovascular outcomes. As you well know, cardiovascular disease is a major contributor in the United States to the maternal mortality rate. And maternal mortality is higher in the United States than any other comparable developed country. So with that in mind, really trying to do our part, this group looked at office visits, for checking your postpartum blood pressure versus text messaging. And so you can see in the blue, dark blue, we have non-Black patients. And in the maroon, we have Black patients here. And you can see that our ability to get blood pressure readings and help manage patients was extraordinarily better in both populations when we were using text message based, did you check your blood pressure? What is it? Let's communicate back and forth. That was automated rather than asking people to make the effort in the postpartum state to come into the office. And it was true for both populations, but made a real difference in the Black population, which is actually a little bit more at risk, actually significantly more at risk for maternal mortality, especially related to cardiovascular disease. So text messaging was optimal, was better than the office visit. So this idea that in person is better than these other things is actually just not true. And we have to start to think about things in that way. What's the best type of care for this situation? And then choose that. So you have to be agile with that kind of care. So cardiac care lends itself to virtual care, but I think this is probably true for a lot of different subspecialties. We can do multidisciplinary conferences now virtually. We have co-localized clinics done virtually, and we even have health and wellness programs. We have stress reduction programs. We have anxiety management programs. We have social work and nursing involvement in those programs, and it's all done virtually now. There is future technology, and hopefully you'll have access to these slides that will come at some point. I think the wearable devices are coming now, and people are starting to send information, so we need to be ready. There are surgery telementoring systems. I don't have a relationship to any of these. These are just ones that have come up in discussion. Eventually, augmented reality video glasses will be useful. Automatic data uploads will be great. We're not there yet, but I wanted to focus on the very last one, which is adjacent integrated solutions. So one place where technology can really help is scheduling, data collection, analytics, payment, insurance claims, all the stuff that we are still hiring people to do in person. I think much of this can be automated with workflows and with technology around telemedicine events. And so I think that's a really important area for larger organizations to focus on is how do we use technology to do this? How do we use algorithms to do this and really make those solutions an integrated part of having a visit so that it doesn't become a barrier to implementing the clinical care that we provide. So how do we do this? I say the first thing is know your landscape. Who on your team is going to participate? Which provider groups want to? Which patient cohorts? Do not make everyone do it. They don't all have to do it. Let the ones who really want to engage with it engage. Let the ones who want to dabble in it dabble. They may find a subgroup in which they will engage as well. Know your equipment and purchase it, hardware, platform, and then peripherals. And then remember that people need training. You need to teach the virtual physical exam. I do this a lot for a bunch of different groups because it doesn't come naturally. We need to establish workflows, I say again, for large volumes of remote patient data. And then having a telemedicine specialist in your group, not just someone who does telemedicine, but who keeps track of what does the billing look like? What is the payment structure? Who are the groups we're working with? That helps create some of those workflows around the back end of the office and providing care. I'm going to skip this. There is research, and there's research to show all of this. Telemedicine improves access, quality, and wellness. It improves provider engagement, which is really important for clinicians right now with the rates of burnout. And patients again and again say it's a sign that the healthcare system respects them. It takes us from a paternalistic or maternalistic way of interacting with our patients to a true partnership. I think that's going to be necessary if we ever want to move away from acute care and really more to preventive care over the next few decades. This is what we used to try and implement telehealth. So the first was quick wins. If there's a simple challenge, is there something digital health based we can do? If there's an ongoing process improvement, can I use digital health to cross the finish line to get more people on board with the idea that it's helpful? What does success look like? And more important, what does failure look like? When are we going to bail on a new system because it didn't work and get people used to the idea that sometimes things won't work and that's okay. We put it aside, we try something different. And then find the right fit. People say, well, we can't do telemedicine because the whole system's not behind us. So that's not necessarily true. You have to determine the magnitude of what is the solution you want and only implement that and not more because you think it needs to be bigger. When you don't have the right use case, that's usually when things fail. This is for reference later, but I love this slide. I go to it a lot. These are some of the virtual services and the CV team and who can bill for what. It is forever changing, so this may not be exactly right a week from now, but these are the kind of things that you want to just think about and keep track of. So I'll go to the future. I think clinician input is essential. This is a reading from a digital stethoscope. The concept is excellent. I actually have some patients who take their own heart sounds because I see congenital heart disease. So these are some aggressive diastolic murmurs people are not used to hearing. And I'll have them keep them recorded on their phone. And I think that's really helpful. I have them take their EKG as well. Because when my patient ended up in Maine with a softball injury and he was in the ER, and they kept insisting, based on his EKG, they said, well, did you faint? We think you fainted. He said, no, I literally tripped over the base. Like, this is what happened. It was a mechanical fall. But because of the abnormality of his EKG and his heart sounds, they had a hard time believing that until he finally showed them both his heart sounds and his EKG. He then used a bad word and says, my doctor blanking says that you shouldn't touch my heart. So that's not what I said, by the way. However, really helpful for people to be able to communicate over distance, because I can tell you, even standing next to my fellow today, what I hear ends in my ears, and then I verbalize the murmur I heard, and I hope that she understands what I said, and then she hears it. Or I write it on a piece of paper, 2 out of 6 systolic ejection murmur, and I assume that somebody else is going to hear the same thing, and it's just actually not good quality care. So I do think, and the cardiologist loves the stethoscope, but I do think our stethoscope is something we've outgrown. I think we need a digital version where we don't just say, here is what I think I heard and hope you hear the same thing. We just give you the sound. Here's what it sounds like. Is the valve forced now or is it not? Compare your sound to mine. And if your ears can't do it, we can do an algorithm based on the phonogram and tell you. So I really think this is where we need to go in cardiology. Lastly, this is Dr. AI. I love this study. This is a study of looking at if you feed, you take a group of heart failure cardiologists. First, you feed them so they're happy in a room together. Then you feed their information, the 6 key things that they agree on that tell you whether a patient is in heart failure or not. And if in heart failure, is the ejection fraction reduced or is it preserved? They fed this to an AI system. And then we compared the accuracy, they compared the accuracy of non-heart failure physicians compared to the AI doctor compared to heart failure. Okay, so the heart failure doctors are our base. And you can see with any form of heart failure, these first 3, the physician was not able to be as accurate as the AI that they fed, right? Everybody could tell this is not heart failure. That was good. We knew when it was asthma and not heart failure as doctors. That was reassuring. But overall, to diagnose heart failure, we actually just weren't that good.
Wow.
Okay? And it's because we don't see it that much. And these are cardiologists too. They're not just any physician. These are just not heart failure cardiologists. So with that in mind, where is this useful? If I'm in the community or in a rural area, I would love a little help. I'm not asking somebody to take away my autonomy, but if you can give me a little hint as to whether I'm headed in the right direction, if I can use it as one more piece of information shy of a full out echocardiogram, right? And the ability to have the echo there and read it, that would help me know where to refer them next, what to do next. And so I think that's going to be the next step of AI, is as a clinical diagnostic assistant. Here's what I think, and this information suggests that my clinical acumen is right. If I think something different, I'm going to ignore that test because I'll still go with my clinical acumen. So takeaways. A blend of virtual and in-person visits ensures high quality, safe care. There's no doubt about it. So the question is not whether to adopt telemedicine, but rather how to best use it in your practice. Successful telehealth implementation is definitely possible, but the ratio of care and use cases is going to vary based on clinician, disease density, patient preference, even time of year. And that's okay. We have to be okay with that flux. And lastly, I think the future of telemedicine is going to flourish with collaboration. So I know we have clinicians in the audience, but we also have companies in the audience today and other people who will watch this. And we really need everybody who's interested in the healthcare industry and telemedicine or digital health to work together if we're going to move this forward. So please feel free. That's my email to reach out anytime. And I will take down my slides so we can do questions. Thank you for having me.
Thank you very much, Dr. Bat. That's, congratulations for all the great work you did at Mass Gen, from 0.23%, to 98% in April. That is really amazing switch in the amount of virtual visits you did there in Mass Gen. I think we have, Dr. George, who is in our audience right now. She's one of our clinicians. If we could ask her for any, oh, Dr. George left. Okay. Anyway, Mr. Majors, do you have any question for Dr. Bat?
Well, it was an excellent presentation. Thank you very much. Yes, I do. How do you handle laboratory testing if you want some testing before the encounter or even after the encounter? How do you handle that?
Yeah, so we've done it two ways, and I think there's something coming in the future. So first is, we have enough different sites that we may just ask them to go to a site, put in an order, and have them do that so that we have the information ready on the day of the virtual visit, whether it's a phone call or other. We have been working with some labs as well locally, so Quest Labs and other things like that, and have them just get it done there or get it done at their primary and have it available as a printout that they can then share and show us if we're on video. I do think point of care testing is coming. So people being able to do their own test in their home. I think it will first go to places like nursing homes and skilled nursing facilities, where there will be somebody with a nursing background or degree that will be able to actually perform the tests locally. And then you can do your skilled nursing facility clinic going from patient to patient because they had point of care testing. I think point of care testing in the home for the average, person is probably further away right now. Than being able to do it with a kind of nurse in a coordinated place.
I think there will be an extension of the physical examination if you could do EKG and echo, at the during your virtual visit. That would be amazing.
Yeah, I think, where we're headed right now, if we do things right, is to be able to have people have their weight, have their blood pressure, their heart rate, pulse ox if you need it, right, depending on your diagnosis. Ready for you when you do a virtual visit, right? And that's not just the day you do the visit, but I think if we can get those data streams to come in relatively regularly, that's important. The reason we don't do that yet is we don't have the right level of coverage, whether it's nursing coverage, we haven't figured out who's the right person yet, to bring in all that data from all the patients who are going to be doing it and say, these are in range, these are out of range. And I think for that, we'll need algorithms. We'll need to say for these people, roughly if you're over 140 in your systolic blood pressure, if you're under 90, it's going to tag it and then have a nurse take a look at that and say, okay, which of these, like, oh, this person's always 82, over 60 because she's a 4'8" grandmother who's 90, right? And so then they can kind of figure out some of the details. I don't think we can give that volume of data without some algorithmic parameters to one nurse to cover and expect them to be able to do it. So we're going to need to get data, have algorithms for outliers, and then probably have a team who does quality check of the stuff that's not marked as an outlier to make sure we didn't miss things along the way. So I think that's the next step to get basic vitals, but I think there's enough groups throughout the country working on it that we should be able to get some system down.
But you mentioned wearables, I believe. And I'm wearing a smartwatch and it, I can do an EKG. It gives me my heart rate. It also has pulse oximetry on it. And I believe it's fairly accurate. I've looked at some research on that topic. That's not too far in the future, is it? Or what are your thoughts on that?
Yeah, so my patients already give me Apple Watch tracings, cardia tracings. Again, no relationship to the companies, just mentioning what they're giving me. And they've been pretty darn accurate. So it's actually been kind of helpful to have. I don't rely on it entirely and say, I'm not going to need anything else to diagnose you now. But if I see it and it looks like atrial fibrillation, I'll bring them in and I'll, get them a patch monitor or a Holter and decide what to do from there. So it's been great. If all my patients started to do that, and I had, 2,900 tracings coming in, I think I would leave medicine. So fortunately, not all my patients are doing it yet, but I think as we have more younger patients growing up and getting into that preventive care age, where they start to kind of show up again, especially, as they have young kids start running after them and then get, short of breath and wonder what's wrong with them. I think we're going to have systems that are ready to bring in those tracings. That's a little more challenging. I do hope companies like Apple and Cardia and all of these other people work with us to actually provide us with the system, right? Rather than us creating a system to take in the readings from them. I would love if they would just say, hey, we have a system, and I'm sure we'd have to purchase it, but we could, figure something out where they would then screen through it the way we would screen through blood pressures and say, here are the ones that you may want to look at first in red, and then second in yellow, and then third in green. If your team, needs a week, it's probably going to be okay. So I do think it's their responsibility in the wearable department to start to provide those kind of platforms and workflows for us.
Well, I think wearables is becoming more common, and I think there's a question from Crystal Cahill asking if cardia is accurate.
Yeah, so I don't know the percentages on cardia. However, I will tell you that it's been pretty good with my patients. And so I've kind of liked having it for patient care. I've had it correctly identify arrhythmias. Again, this is anecdotal. In the past, I've also had it correctly show sinus rhythm when the patient clinically definitely was not having an arrhythmia. There was something else going on and just, was worried about the cardia. So I'm not sure the percentages off the top of my head of what that precision or accuracy looks like, what its sensitivity and specificity for different arrhythmias is. But I've been okay with people giving it to me so far.
I think we have a question from one of our medical students, Angie Kim. Angie, can you unmute yourself and ask Dr. Bat your questions?
I would, but I'm in the ER, so it might be a little loud. Can you still hear me?
Absolutely.
Okay, so Dr. Santos, I don't know if you already have this information from Dr. Bott, but I was just curious to see if you had a specific structure or model or curriculum that you pulled from for your virtual physical exam.
Yeah, so we've created a few. So one, the American Medical Association has some in their digital health playbook. We are putting out through cardiology a workbook on how to do telemedicine that also includes the things in the physical exam. And then over at Harvard Medical School, we also have a curriculum there that we've been using. I think there are a couple other universities that also have that. And so that's what we've been doing. I myself, when I teach, probably should use all of their curricula, but instead I've just read all of them. And then depending on who my students are on the Zoom room that we're in, I'll let them ask questions about the things they're nervous about, and I'll just go through, my basic physical exam. I'm happy to share my slides with you.
If you don't mind, I will follow up with an email later.
Absolutely.
So you have my email. That would be great. Thank you so much.
I'm happy to share them, and feel free to share further.
Okay, thank you so much.
All right. And also, Texas Tech also had a Frontiers in Technology laboratory, and we are actually revising all our curriculum to, make sure we were able to teach students how to do direct to patients, unlike before our old curriculum, had the presenter with them. I think we cannot get away with the presenter, but I think we had to tailor it with the changing times. Dr. Bay, I have a question though. You mentioned about metrics, on how to know whether you have a successful telemedicine program. What are the metrics you've been using at MGH?
Yeah, so I think the first and most straightforward thing is patient engagement, right? Out of all the patients you offer to, how many are using it? And I also use clinician engagement. Out of all the people who could use it, what does their volume look like? And I think that's just important. We do have the same metrics that we use, like the CG caps that we use for patient experience. We'll use the same patient experience metrics for virtual visits as well. And so that's actually been incredibly helpful in just demonstrating that patient experience has been equal, if not better, with virtual visits throughout the country, actually, than in-person visits. The most common things that people cite in patient experience have been, of course, cost of care and travel time, but also the things that have stayed steady are ability to understand your disease process, ability to communicate and be listened to by your physician. And so patient experience has actually gone up with the use of virtual visits really throughout the country. So that's been a good one. And then outcomes is going to have to be the next step, right? So that needs to then be disease focused. So for us in hypertension, we are now trying to measure how quickly were we be able to make changes in blood pressure management when we sent blood pressure cuffs home. So the first thing we did again was similar. If we send it home and we said, take your blood pressure before and after your meds twice a week, the first thing was how many people did that? It was like 15% of people the first time. And I was like, oh no. And so then you try and understand, why is this happening? What can we do differently? Do they need text reminders? Do they need a live setup? And did we just assume that they could do it, but we never actually double checked that they were able to send the first one? So we learned some things for that. We redid it. We got up to a greater percentage of people who are contributing, still not 100%. And then it became, how many med changes did we make in this population? How quickly did we get their blood pressure to goal? And so, that was kind of the next step for us. The CGM literature, so the continuous glucose monitoring, right? And the platforms like Livongo, who have taken on all of diabetes management, right? And created a platform based on it. They've done a brilliant job of being able to say, look at outcomes. I can drop your hemoglobin A1C by 2 points in 3 months using this. But that's hard. That's hard to fathom, that kind of a controlled system being realistic as a next step from the kind of care that we are providing today, which unfortunately in this country is still kind of piecemeal, right? There is the ER where Dr. Kim is right now. And then they come to the cardiology office, and then their primary care may not be in our system. And I can't get their ER notes, even though they're on Epic and we're on Epic, but care everywhere is not working. So there's a lot of, there's still a lot of pieces that don't flow well. So I do think that the systems like a Kaiser or a Geisinger, or, even some of these new companies that are doing all encompass, like we take on the responsibility for insurance and healthcare outcomes together. I think those are the kind of companies that are going to be able to advance virtual care the best, because they're really in control of outcomes and cost all at the same time. Whereas the rest of us have just too many factors going into that control.
Dr. Batch, you mentioned the multidisciplinary conference, and I think that's a huge advantage for telemedicine. Do you have the ability, let's say you're prescribing a statin, can you invite a pharmacist to join in the discussion or that sort of thing? How does that work for you?
Yeah, so John Marshall is one of our heads of pharmacy and at Mass General, and he's great because we are working now on a system where they actually zoom in on the virtual visits. So when we are towards the end of our visit and we're talking about, the nutrition aspect or whatever else, they'll then zoom in and then they'll do the actual kind of further education, especially with statins, the reassurance about the side effects and how to communicate. And so we're able to do that. We're also right now just working towards getting a social worker for our individuals who have some developmental delay, and there's somebody interested in that specific population, to again have those individuals be able to either coincide with our visit or just schedule at a separate time discussions with our patients in order to help them with whether it's finances or understanding what they're doing or their diagnosis. And so that's been great. And then the third place is the Benson Henry Mind Body Institute is based at Mass General. And so we had them run a resilience course. So health-related anxiety runs a lot in cardiac patients. So we had them enroll patients in group virtual resiliency training. And so each week they talk about different things about, when you hear that somebody else had a heart attack, why do you suddenly feel chest pain? How can we get over that? And the patients just loved it. And it was small group format, but it was group resiliency training for health-related anxiety. And it also decreased the number of phone calls to our office immensely. It was actually really impressive. It helped the whole team, including the patient.
On the patient-reported outcome measures, the PROMs, do you send the patient a questionnaire or something that you expect the patient to answer, like how far they can ambulate or something about angina? Do you do that? Is that related to the, kind of an episodic visit, or is this more of a longitudinal thing?
So we used to do, there was a lot of excitement about PROMs about a couple of years ago. And we used to do PROMs directly with the patients when they came to the office. Then we uploaded the PROMs to our electronic health record, and we started to send it to them and see if they'd respond that way. Then COVID happened. And last week, I probably should have changed this in my slide deck, in fact, from when we first planned this. Last week, we got one and then word of numerous emails from patients saying, why on earth is there a 23-page questionnaire that I'm forced to answer every time I have a virtual visit? So I think the utility, and this is why I go back to what is the right size answer, the utility of asking everybody everything all the time, we are wearing them down. I think if you had angina within the past 6 months, Should you get a Seattle angina questionnaire with the limited, like only 9 questions to answer, right? Maybe those are the people who care and say, hey, I'm glad they're asking about my angina. I just had this episode, right? So I think we have to really be much more particular about who we're going to interact with in an asynchronous fashion and just send them stuff and want them to fill it out, because we all get so much junk sent to us that it's not going to really improve care. It's a great question.
Well, I agree with you. I think we're all suffering from survey fatigue. You know, the least little thing you do, you have to complete a survey. I mean, you're asked to, you don't have to, but yeah, I think it's a good point.
Well, I would like to applaud you as well on looking into the equity questions on telemedicine, and I think your paper with Dr. Brown and Mathenge are actually answer some of the questions. But as an institution, as MGH, as Harvard, what do you do to optimize and reach out and bridge the gap, on people of color as well as low socioeconomic status who are, obviously being affected by the disparity in telemedicine?
Yeah, we have some great leadership at Harvard, at Mass General, Brigham. One of my really good friends and colleagues, Sherry Ann Burnett Bowie, has been working on this for long before everybody else had. And there's actually now a division equity director. I may have the terminology wrong a little bit, throughout the Department of Medicine in every subgroup. So for endocrinology, for GI, for cardiology. And those division equity heads are together now starting to talk about how do we ensure we're reaching out to the right communities? How do we ensure that we're asking the right questions? How do we build trust in that community? And so I think that kind of this is one place where that kind of a large scale concerted effort is necessary for us to make changes. So meanwhile, people like myself and Kamar and John B continue to do our grant mediated work on, can I get into the community? Can I get a tablet in their hands? What is not working when I try and do that? Where does it fall apart? And I think that kind of research and small group efforts are important, because hopefully we will inform the larger picture by doing these trials and doing the pilots. But I think if you don't have an institutional buy-in to address it kind of from every single level in every arena, we're not going to be able to do it right. So unlike digital health, where I say don't buy in for the whole system, find your niches, start to do it, and let people build themselves. I'd say while it's great that those of us who are interested will do the research, I think it's even better that there are people who do this as their full-time job for our institution.
Just one, I know we're out of time, but you talked about social determinants. Some people talk about they can observe things via telemedicine in the home, even to the point of, would you show us inside of your refrigerator? That seems kind of extreme, but you get a good sense of what's going on with the family. And then maybe that falls in the social work realm, but have you been involved in that sort of thing?
Oh, every time somebody gets on a screen, you learn so much about them. So seeing the environment behind my patient, I think is essential. Seeing who else is on the screen or behind the screen or signaling from behind, but you can tell because they keep looking up to see what they say and then ask their question. I think that's been really helpful. It's also been incredibly helpful to have family present, because we think medicine is easy and people understood what we said. They didn't understand what we said a lot of the time. And this is true for even the simplest of routine visits.
Mm-hmm.
So to have them in the comfort of their own home, they're actually more likely to ask you to repeat again what you said. To have their family around is helpful, because those people will then ask questions on their behalf, and they can't always visit the office with them. We did a study with Cass Sunstein a couple years ago where we actually looked at type 1 versus type 2 thinking. So this is fast thinking where you're just on the fly going versus slow thinking where you can process and learn better. And we found out that our patients, when they come into the clinic, they were all fast thinking. Nobody was in the slow, I am in the learning ability. There's actually a questionnaire test that you can have people do. Nobody was in that. The majority of patients were in that fast thinking where we know that they're not good learners. By the way, what we did in that study was negative. we tried to give them a prompt to help center them and see if they were thinking better. They weren't. It didn't work. So that was like, it was great evidence that like prompts didn't work for that. We're now repeating that study for our virtual visits to see if people are more in that calmer type 2 zone when they're sitting on their own couch in their own home, engaging with their doctor rather than in a blue gown, in a freezing cold room, on top of a plastic sheet, having met 7 people already and now being 45 minutes late to see their doctor, right? I can't imagine that I'm going to be wrong about the answer to this one, but I've been wrong before, so we'll just see what comes out of it. But I think there's a lot to be said to engage in your own care from the comfort of your own home and feel like you're really in the driver's seat.
Thank you so much for today. I'll turn it over to my friend, Dr. Santos.
Yes, so don't forget to do your session evaluation using the QR code over there. And Laura will send it out as well. Would like to thank Mr. Majors for co-moderating this webinar with me. And thank you, Laura, for doing our IT help here. Next slide, please. And as our token of our appreciation, next slide, we would like to present you this challenge coin. Click again, Laura, and we will mail it to you, this challenge coin for your excellent presentation and webinar. And for next month, next slide, please. We will have another webinar. It's about telemedicine in correctional facilities by Dr. Shallow, Will Rodriguez, and Dr. Jumper. Again, thank you very much, Dr. Bat, for the excellent presentation. We really appreciate it.
Thank you so much for having me. Be safe, everybody.
Thank you.
Thank you. Bye-bye.